Next time. So we're predominantly going to be talking about head and neck cutaneous melanoma, and specific details or facts related to head and neck melanoma is that it accounts for 15 to 30% of all primary melanomas, as there's generally higher levels of exposure and higher melanocyte counts. There's also associations with higher rates of local recurrence and regional lymph node disease, as given that the head and neck melanomas, they're often more difficult to resect. And also there's a more complex regional nodal distribution, specifically the parotid and the cervical lymphatics, which are common sites of spread. In terms of the cutaneous melanomas, there's some major subtypes, specifically the superficial spreading, nodular, lentigo maligna, acrolentiginous, and desmoplastic. But the primary focus of the talk today is to, one, speak about the management of melanoma and also the predictors of metastases, specifically to the sentinel lymph nodes and the regional nodal basins. Specifically, which Andrew will speak about shortly, are the Breslow thickness, ulceration, mitotic rates, lymphovascular invasion, microsatellites, perinodal invasion, and lymphocyte infiltration, which are predictors of metastases. As any good doctor would, obviously there's a concrete history and examination that are associated with melanoma. Again, we won't really touch on this too much, as it's essentially quite general and very broad. Moving on to Andrew and some of the histopathology.
Yeah, so some of this is a bit of repetition, but to set head and neck melanomas in context, the head and neck region is unique in that it's host to a range of different melanomas, of which cutaneous is common, but certainly mucosal melanomas, uveal melanomas, and conjunctival melanomas, all of which have their own AJCC staging system present in the head and neck. Each of these diseases is clinically, epidemiologically, and genetically distinct diseases. And in this talk, we're talking specifically about cutaneous melanomas. And I just wanted to drill down a bit further on cutaneous melanomas. The classification of cutaneous melanomas is evolving at the moment, and there's a push to have an integration of more traditional histopathologic morphology with genetic features. And on this diagram, I've summarized basically cutaneous melanomas can be split into those which arise in chronically sun-damaged skin, of which the head and neck is a classic example, and those melanomas that arise in more intermittently sun-damaged skin. And the two overall pathways, really, the chronic sun-damage pathway involves lentigo maligna, otherwise known as Hutchinson's melanoid freckle, progressing through to malignancy such as lentigo malignant melanoma and desmoplastic melanoma, whereas the more intermittent sun damage begins with a benign melanocytic nevus going through to superficial spreading melanomas or nodular melanomas. And to go further into the distinct features of these two, clinically, the chronically sun-damaged melanomas arise in older males and tend to be in sun-exposed areas, as I said, typically head and neck, in which histopathologically we see extensive solar elastosis, whereas the non-CSD melanomas arise in young adults living usually on the trunk. Genetically, they also show distinctions. The chronic sun-damaged ones tend to be BRAF or NRAS wild type with NF1 or KIT mutations. They also have much higher somatic loads, whereas the non-chronic sun-damaged tends to be BRAF V600E with a much lower mutational load. There's obviously overlap. These aren't perfect distinctions, but they seem to work fairly well. So I'm going to discuss the three of the most important critical parameters in primary melanomas. Daniel's already referred to these: Breslow thickness, ulceration, and mitotic rate. The Breslow thickness, which is far and away the strongest predictor from a primary melanoma, is simply the perpendicular distance from the granular layer of the skin to the deepest aspect of the tumor, and I can try to illustrate that with this yellow line in this melanoma. So if you can see, the silhouette of the tumor goes down to just the bottom of the line and starts up at the granular cell layer. Ulceration, this is where there's a break in the epithelium above the tumor. There's fibrinous debris and necrosis. So this is true ulceration as opposed to surgical artifact or traumatic artifact. And finally, mitotic rate, which is measured per square millimeter of tumor. In the most recent AJCC, mitotic rate is no longer used in the T staging. However, it's a critical parameter because it still shows prognostic importance, and presumably it will be involved in staging systems and prognostic systems as they develop in the near future. So just briefly talk about the staging in melanoma. With the 8th edition of the AJCC, there have been some changes with the T, N, and M stages. With the T staging, interestingly enough, they've moved much closer to Breslow's original distinctions of stage. So T1, which used to be divided on the mitotic rate, no longer uses mitosis. It is divided purely on depth. So less than 0.8 millimeters is T1A was the best prognosis, and more than 0.8 millimeters is 1 millimeter is now considered T1B. And then for the other for T2, T3, and T4, they have thresholds of, you'll see 1 millimeter, 2 millimeter, and 4 millimeters, and alteration will up stage each one of those. Node count hasn't changed that much. Again, it varies with the number of nodes, positive nodes, and you can read this in the AJCC as required. And metastasis has changed quite significantly. You'll see that now M1 has been split into M1A, B, C, and D, depending on which tissues are involved. So confined to skin is M1A, lungs only is M1B, other visceral sites M1C, and CNS is M1D. This is a recognition of increasing clinical data showing the different outcomes of these different subtypes. And LDH is no longer in the actual M number, it's a separate indicated by a number, again showing how important LDH is in staging. And again, this is a summary for your own reading at some other time.
So before we proceed to the cases, while waiting for comments, can the expert panel sort of give us an idea of why the change from a 7 to an 8 in terms of dropping off the mitosis and changing the parameters?
I think what Andrew was saying is that they did some more research and they just really teased out that something happened at around 0.8 millimeters that really showed the increase from around 0.8 to 1 millimeter. There was a definite splitting up of the curves. And so they decided, I think, from that reason to make that the cutoff for 1A, 1B, and so that was the reason rather than, it was more of a predictor than the mitotic rate, which is in the previous AJCC.
The original, so the 6th edition, if you go back to the original Breslow conception, the threshold was 0.75 millimeters. And so really, if you've gone back to the future, 0.8 is just a recognition.
So it was in his initial research, I think he found that, and they found that's actually running true. Around 0.8 millimeters. Something happens at that level. We're not exactly sure, but something happens around that Breslow thickness to increase the risk of metastasis.
And dropping off the mitosis?
I'm not exactly sure why that occurred. I presume it was just more of a predictor was the Breslow thickness, and so they would decide to go for that and to simplify things rather than adding another variable.
We might go to the cases as a few things to come.
These are actually Dr. Shannon's cases. First case is patient by the name of MW. She's a 67-year-old female with a large pigmented lesion on her occiput. She had an incisional biopsy, which was performed showing malignant melanoma. This was in a facility outside of Lighthouse or RPA. Showed a Breslow thickness of greater than 3.5 millimeters, cross level of 5, mitotic rate of 9, with no LVI, PNI ulceration, or microsatellites, and as such was staged as a PT4 according to the 8th edition. The question was, in this type of scenario, what further investigations, if any, need to be done to further investigate?
So I might bring it back a little bit. So for sort of the clinician and managed melanoma, incisional biopsy versus excisional versus shave. Do you want to comment a little bit before we move on?
As pathologists, we want as much as we can to make a diagnosis and to give prognostic information. Our college generally, our guidelines are we do not like shave biopsies of pigmented lesions because then once you take a shave biopsy, you're actually trying to calculate the Breslow thickness once you've taken the shave and you're trying to work out actually how thick it is on the actual complete re-excision. It's very difficult to work out the Breslow. So our guidelines are, if it is possible, to do an excisional biopsy if it's a concerning lesion, definitely not a shave biopsy.
Okay. And so at this point, you got an incisional biopsy, not an excision, so you don't know the size. You have a thickness level that is
At least.
big.
Yep, so it's at least. So we know it's a thick melanoma, I suppose. So it's an at-risk primary, if it's greater than 3.5. It's got a fair few mitoses, so this is a high-risk melanoma.
So at this point, someone with a singular pigmented lesion with that incisional biopsy, how would you investigate this patient? Anyway.
Yes. So there are two things that I think Colin needs to help here, but you need to do, of course, a wide local excision and a sentinel lymph node. That's really key here, okay? But of course, you also need some imaging, and at MIA, definitely, and then according, of course, to the result of the sentinel lymph node biopsy, you need to have imaging in terms of PET scan and MRI of the brain. That's how we go. And then according to that, we can decide further, but that's what we normally do.
And so up front, this patient comes to the room, they'll get PET scan and MRI of the brain.
Correct.
Well, before we do a sentinel lymph node.
No. Sentinel lymph node. You need a sentinel lymph node. Let's assess the risk first.
Oh, right. Okay. So sentinel lymph node first before MRI. Oh, I look at the risk and then decide whether or not you need to go for PET scan.
Correct.
MRI.
Exactly.
We're saying the sentinel lymph node gives the best prognostic
Correct.
information.
Exactly.
Over and above a staging species or PET scan.
That will determine if this patient is stage 2 or stage 3.
And what's the cutoff? I mean, what's the cutoff for any pigmented lesion or any melanoma for sentinel lymph node?
That's a certain question, but in general, it's 1 millimeter. But there's also a 0.8 to 1 that if there is ulceration, should go for sentinel lymph node biopsy. That's a certain.
Anyone is kind of T1B.
Correct.
You would definitely go for sentinel lymph node.
Yes. And then determines the risk, and then we go for further investigation. Yes. That's when they come to us.
Right. Okay. We might carry on with that. We'll leave the margin discussion until Kerwin comes.
Yes.
So we might sort of fly through those slides.
Sure. So in terms of investigations at this stage, they hadn't had a sentinel lymph node biopsy, and so that's something that they would need to have done first with wide local excision. But just in terms of the evidence for imaging with early stage melanomas, there isn't a lot of evidence to
Can I add one thing? Yes. So that's a good point. In fact, we have been discussing in MIA in our multidisciplinary meetings that we don't have evidence for how to follow those patients, right? So this patient is a more complex case, but let's say that we have stage 2 or stage 3 melanoma patients. We don't know. There's no guideline, no specific guidelines, how frequent, and what kind of imaging we should do. That's why evidence grade 6 here. Yeah.
which isn't great evidence, but there's some evidence to suggest. We were going to talk about surgical margins at this stage, but I was talking about...
We might fly through this, but we'll come back to the surgical margins because there are a lot of things that we need to talk about.
Lots of studies, anyways. Cancer Council of Australia has made their recommendations, and this is essentially with grade B evidence what we like to do our excision margins with. Of course, with the head and neck, the margins often aren't as wide, such as 2 centimeters. That's not possible, so sometimes those margins may need to be adjusted somewhat. So the patient underwent a wide local excision and a sentinel lymph node biopsy. In preparation of the sentinel lymph node biopsy, they had a lymphoscintigrogram, and this showed bilateral lymphatic drainage from the scalp vertex melanoma with 7 sentinel lymph nodes. Of note was an ultrasound done at the time did not show any evidence of melanoma metastases. Next slide is just a report of the lymphoscintigraphy, which shows essentially timed activity from 0 seconds to 7 minutes, and then on the right you can see the delayed picture showing all the essentially glucose-avid hotspots.
So the images are presented in 2 ways. One is real time, so across different times to look at how the drainage pattern is and which is the first echelon, which is second echelon. And then there's also on the next slide
the CT lymphoscintigram, which shows actually the hotspots on the CT. So the picture on the left is the initial injection site, and then you can see the nodes lighting up with time. And then this is a kind of 3D reconstruction that was also presented with that same study.
So this patient underwent the one-log excision and the central lymph node. So we got the pathology, and we might then discuss based on that. We might come back to that missing gap afterwards.
Yes.
Let's go to the pathology, and we can come back to it again.
So these are photomicrographs from the wide level excision. This is a section of skin with a surgical site. It's a relatively recent you know, all the hair follicles consist of origin from scalp.
Actually, Andrew, yes, Kerwin is here. We might just follow the flow a little bit. Do you mind if we just go back to the...
We did say we would say, thank God you're here, Dr.
That was prepared.
How we got to?
We've skipped over the surgical margins in preparation of your arrival. So historically, the margins were 5 centimeters, and those were common practice, until the evidence seemed to pile up that there should be specific margins for specific Breslow thickness.
So when I started on the melanoma unit, the thin melanoma's got a 2 centimeter margin, and thicker tumour's got a 5 centimeter margin. You can imagine that we're doing these dinner plate excisions for people. Then there were these trials. I've got the WHO up there, which compared 1 versus 3 centimetres for melanomas up to 2 millimetres in thickness. Found no significant difference between the two, but in those tumours between 1 and 2 millimetres who had narrower margin, there was perhaps an increase in local recurrence without any death and survival. In the intergroup studies that was 2 versus 4 centimetres for melanomas, 1 to 4 millimetres. And surprise, surprise, the only significant difference between the two groups was that the 4 centimetre margin needed skin grafts more often. And so basically, and then there was the Swedish study and the batch study, and essentially there's no evidence that taking more than 2 centimetres has any impact on survival. There is a suggestion that the thinner intermediate tumours, if you take a narrow margin, there might be an increase in local recurrence. But the other important thing is not many, if any, of these trials had head and neck as a primary site. So we don't really have any good head and neck data at all. We've recently done at least the pilot part of the MELMART trial, the melanoma margins trial, looking at 1 versus 2 centimetres for all thicknesses, and sort of mature data from that sort of come out. So what does that mean for head and neck? I will take 8 centimetre and up to 2 centimetres, except where the difference means the difference between losing some important anatomy or requiring a more complex flap. So, for example, if a 1 centimetre margin on a thick tumour on the scalp means I need to do a skin graft, then I'll take 2 centimetres. But if I can get a primary closure with 1 and I need a skin graft for 2, I'll take 1. But I'll talk to the patients about it, that I'll, not putting your survival at risk, but there might be an increased risk you'll be back to take a little bit more down the track. So that's margins. 2 where you can get it, otherwise at least 1.
And your depth, Kerwin?
Well, the depth is down to the next fascial plane. So on the scalp it's easy because you've got nice layers there, and you take a vertical incision downwards onto the deep fascia in whichever tissue that you're taking. The one place where that can be tricky is sort of around the midface, where you tend to lose. The case I've just done, actually, that's a good case in point, lymphoma malignant melanoma on the cheek. And what I generally do for those is someone that needed a flap to get it closed anyway, even with a 1 centimetre margin. But as I develop my plane back over the parotid fascia where it's obvious, and raise it like I'm raising a flap for parotidectomy, and then having raised the flap in the appropriate plane, I then cut the primary off the flap. So that's one way of getting the deep plane on the face, but otherwise you're basically taking a decent guess, and you just stay above the plane of the face. Although the more anterior you go, the nerves will probably disappear in the muscles by then.
We had discussed patient MW and the wide local excision and sentinel lymph node biopsy, and the results of their lymphoscintigraphy. And we were going to talk about the rationale for sentinel lymph node biopsy. And I'm sure many people have heard of the MSLT1 trial, which is the multi-center selective lymphadenectomy trial. And it's obviously a phase 3 randomized controlled trial comparing wide local excision and observation versus wide local excision sentinel lymph node biopsy plus or minus completion node dissection. The findings that I found very useful or surprising was that there was central lymph node involvement in 16% of sentinel lymph node biopsies, which it's a number of 16, it's not high, but it's there. And obviously the positive result was that patients with an intermediate thickness melanoma, which is defined as 1.2 to 3.5 millimeters, had an increase in 10-year melanoma-specific survival, and the rates were reported there. But overall, in the other subgroups, there was no difference in melanoma-specific survival and no difference in distant disease-free survival. And the status of the sentinel lymph node was the strongest predictor of 10-year melanoma-specific survival.
Well, this was a trial that caused an enormous amount of controversy over the years. I didn't have too much difficulty with it at all. I mean, when you've got a positivity rate, when you look at the more mature data, when the positivity rate is approaching 20%, when you add the false negatives onto the SMB positive, both groups are about the same in the long term. And the implication is very strongly that if there is disease in the sentinel node and it's allowed to progress, it will. So there's the data that over time those two lines come together at about 7 or 8 years or something, that they run into each other and remain together. We've got some indirect data from the melanoma unit when it wasn't required in the protocol, but every time we did a sentinel node biopsy, sorry, this is an MSLT2, where someone was going to be observed, we put a tattoo there, and those that failed almost invariably failed under the tattoo marking the side of the sentinel node. So, you know, it's where you'd expect it to turn up. But with 16%, that means 84% of people are never going to benefit from a more extensive operation. And so any effect there might be is diluted by that 80%. And there was some suggestion in the mature data that there is melanoma-specific survival between the two groups, but there was a little bit of statistical fudgery that was used to display that. But really, I mean, to my mind, this was never a trial looking at using sentinel node biopsy as treatment in someone with stage 2 disease. It was a trial designed to see whether you could identify the subclinical stage 3s and improve their survival by early intervention. And when you looked at the positive patients in each of those two groups, there was a very significant difference, you know, something like 73 versus 53% difference in 5-year survival rate. So if the disease is there, it's better coming out early. MSLT2 has thrown a spanner on that, and when we haven't got to decog, we can talk about it again later. But certainly as a staging procedure, there is no doubt about the benefit of this, and you know, it gives the patients more prognostic information than any of the information in the primary. It allows you to stratify people for clinical trials, and it certainly increases regional control, and you know, there was still perhaps a slight melanoma-specific survival advantage in the long term.
So before we move away from the sentinel lymph node, can you just briefly talk to us about your testing, as in what tools you use to use?
So there was a paper published by the unit which showed that to get the greatest accuracy in sentinel node biopsy, you needed preoperative lymphoscintigraphy, and that's because there are things that don't turn up quite where predicted, contralateral lymph nodes, particularly in the trunk and things going south when you expect them to go north, and vice versa. So you've got to know where to start looking with your probe. Then in the theatres, using intraoperative blue dye. So you've got a colour guide as to where the lymphatics are running and to help you identify the sentinel node. And you doing the linear scintigraphy close enough to the procedure that you can still use an intraoperative gamma probe to detect it. And if you've got a hot node that's blue with an afferent lymphatic running into it, then that you can be sure you've got the node that was mapped. There were some people who would not do the lymphoscintigraphy, they just rely on what they could do in the operating theatre, or they'd still inject the radioactive tracer. But if you've got a node over here and you're looking at a right neck primary and you don't put the probe over there in the theatre, you wouldn't know to go looking there. So it's important that you know where you're looking before you start. In the head and neck, I always look at the SPECT scans that are done at the same time to let me know, is this a node that's superficial to the sternomastoid or deep to the sternomastoid, because they'll call parotid level 2, level 1B, all in the same area. And by looking at the SPECT scan, you've got a much better idea of how deep. Is there something hiding underneath the mandible? Is there something back in level 2B that you might miss the probe initially just because there's layers of tissue in front of it. So if you know where you go looking, you're much greater chance of finding it. And the trimodal approach, 95% of patients you expect to find the node you're looking for.
Can I just ask, the study has found a positive difference in that intermediate thickness melanoma, and yet our cutoff for doing a sentinel lymph node biopsy is 0.8 millimeters. What's the rationale between obviously it's not 1.2 millimeters, which you would expect from the trial, it's 0.8, which we know is a prognostic marker?
Well, the MSLT1, the group that they looked at was that intermediate thickness group, but in fact on study there were patients, there were some thinner patients, there were patients bigger than 3.5 millimeters. And this was the group historically where you expected to find the greatest difference. In the thicker tumours, the rate of systemic metastases is significantly higher, so dealing with the regional disease earlier might not make any difference. And in the thinner group, the rate of nodal and systemic disease was so low that probably wasn't going to make any difference. But there is a group of patients thinner than a millimetre with higher risk factors that have a higher risk of having positive sentinel lymph nodes. And they're younger patients with invasion, ulcerated primaries, plaque level 4, and younger patients. And there is a publication now looking at the risk in thin melanoma specifically, and certainly no one under 0.5, whatever the other risk factors are, ever has a positive sentinel node. But most of them are in the sort of 0.8 or greater. So 0.8 with another couple risk factor or two would still put you only in the risk with sort of 10-11% chance of positive.
This H&E from the wide local from this lady, again, showing as got features typical of South origins, there's lots of sebaceous glands and hairs, and there's inflammation around here consistent with the recent surgery. In this particular wide local, there was melanoma in situ, and atypical melanocytes making confluent runs along the dermoepithelial junctions of the basin here. And then I was just going to discuss briefly about sentinel node tumor burden. This is something that's touched on by the AGSCC, and this is an area of ongoing work. There's good evidence that the sentinel node tumor burden correlates with with positive non-sentinel lymph nodes. And the AGSCC currently recommends in pathology reports of sentinel lymph nodes that they give at least the single largest maximum diameter of whatever deposits in the sentinel node. This is the single largest discrete nodule, and in the AGSCC they make reference to the fact that this is a point of ongoing discussion with international groups as to what is the minimum data set required. So at RPA/MIA, there's actually quite a lot of evidence. The number of foci of tumour, the largest focus of tumour, the area of the sentinel lymph node involved, and the maximum penetrative depth, that is the depth from the capsule of the lymph node into the actual parenchyma. Each of those has evidence behind it as to the risk of non-central lymph node positivity. We also give perinodal lymphatic invasion, extranodal invasion, and whether or not there's a nodal nevus as well. So I've got some histopathology of central node positivity. This is a lymph node here, and with our special stains, you can see that this pigmented deposit within the lymph node parenchyma. These cells are pleomorphic with prominent cytoplasm filled with melanin. There's prominent nucleoli, very typical of melanoma, and with immunohistochemistry using a red chromogen because of that brown pigment. They are F100 positive, melan A positive, and HMB45 positive, so typical phenotype of melanoma.
Maybe it should be also noted that central nodes, we do treat central nodes differently than normal nodes. That's why it's important to know that it's a central node. So we cut deeper into the node, and as you can see, we do immunohistochemical stains, usually to pick up the smaller deposits that are difficult to find, H&E. So there is a different protocol that we use. We look harder for the smaller deposits. Then if a lymph node comes, we just cut once into the lymph node. A central node, we do multiple cuts and do further stains. We'll talk for actual.
Do you always do immunohistochemistry?
On every single central node, yeah, I guess what we call a central node protocol. So with melanoma, we do to cut into the specimen, we look at a couple of H&Es, and in between that, we do 3 different immunohistochemical stains looking for deposits of melanoma. Same as we do in breast, we do the same thing, but we do keratins looking for deposits of breast cancer.
So the results of patient NW's histopathology showed in situ melanoma 9 millimeters from the left peripheral margin with no invasive components, and 3 out of 6 central lymph nodes which were positive for metastatic melanoma.
So just to clarify that, so this patient had previous incisional, so this is now wide local. There's no
residual invasive component, but it was invasive melanoma.
So at this point, you've got 3 out of 6 sentinel lymph node positivity, and clear good margin on the primary. Might start with the reverse way, or start with Ines. What would you do?
Well, with this patient, definitely I would discuss with the patient adjuvant treatment. And I can explain a little bit why, and of course, small details here in Australia. So what we have available here, so we have a patient with high risk of recurrence, right? That's what we have. And when the patient comes to us, medical oncologists, what we explain is that we don't have any evidence of disease at this time point, but there's a high risk of recurrence. And in general, we explain, to keep it simple, that let's say that the patients have a 50% chance of recurrence, and if we don't do anything, yes, the patient might be in the 50%, 50% that nothing happens, which is great. But if the patient is in a group that will have recurrence in the future, then could be a problem, because it can be local recurrence or distant recurrence, and that's what we want to avoid. By giving adjuvant treatment, and I'm talking about, and then we can think about local, and I'm going to do that for Angela, but I'm talking about systemic treatment, then we have 2 main strategies nowadays. One, I don't know if this patient can be eligible because we don't know the BRAF status. Another one is immunotherapy, which is completely independent of the BRAF. So just BRAF is a mutation that has, as you mentioned, can around 40%. In this case, we'll expect less than that probably, and if present will be more Viscent K, so not Viscent K. But let's focus on immunotherapy. So we have target therapy to block BRAF or immunotherapy. So which evidence do we have? We have one trial that compared PD-1, so which is pembrolizumab, one of the PD-1s, versus placebo, and we have a risk reduction of recurrence around 50%. Doesn't touch the 50%, but almost there.
So this is regional recurrence or distance recurrence?
Both, yeah. We don't have mature data in terms of overall survival, okay? And we have another trial, which I think is also really interesting, which is the comparison between ipilimumab and nivolumab, so which is anti-CTLA-4 and another anti-PD-1, right? So we have previous data showing, which was the first effort, showing that ipilimumab alone versus placebo, we have a risk reduction of recurrence around 11%, and then we have that comparison with a benefit of nivolumab, so PD-1, similar to pembrolizumab, so the same, just different companies, with a risk reduction around 40%. So if you put together, they are kind of similar. We have a risk reduction of 50%, with no mature data of overall survival. But we know from stage 4 that these drugs, when they work, they tend to be long-term, right? So we have kind of this idea that if immunotherapy works in this patient, it's good. That's one thing. Especially with BRAF mutant, we have the tablets, and so target therapy, where we have mature data that we have a benefit of overall survival. So risk reduction similar, but we have benefit in overall survival. Problem nowadays, we discuss all this with the patients. We can prescribe, but it's not sponsored by PBS yet. And we have discussed like funding and, you know.
How long do you need to expose them to?
That's a good question, sorry, yes. So for both treatments, it's 1 year, okay? So just to clarify, PD-1, so let's say pembrolizumab would be every 3 weeks, and the bafinatinib would be during a year, and it's every day tablets. So yeah, one is like 2 tablets twice daily, one is 1 tablet daily, and that's it. Yeah, but it's a year.
And would you need to do anything for these patients considering they got bilateral sentinel lymph node positivity?
No, there's no data suggests that with this type of tumor burden, there is benefit for radiotherapy. So radiotherapy is more for macroscopic disease, depending on the number and size and string of the spread, but not for positive sentinel lymph node.
So when has your approach changed before and after MSLT1?
MSLT2, very definitely changed. So there were 2 studies that came out looking at patients who had been randomised to, well, they all got sentinel node biopsy, and they were randomised if they were positive into observation of the second-tier lymph nodes versus immediate completion node dissection. The whole point of MSLT1, as I said, was to identify people who would benefit from early intervention. And so the standard of treatment had always been that they needed a completion node dissection. For a long while, even in these trials that were done, to get onto the trial, they had to have had a completion node dissection. Both the DCOG study and MSLT2 just show the survival curves directly superimposed on each other. So there's no survival advantage in having the remaining lymph nodes taken out. And I initially, when I saw the DCOG data before MSLT2 had been published, didn't quite understand that, because if early intervention was the issue, why isn't there an improvement? And it came out in the MSLT2 paper that if you fail in the lymph nodes after a positive sentinel node, very infrequently is that the only site of recurrence. And I think it's something in the order of 6% of people will fail in the nodes alone, whereas everyone else has got other systemic disease, which presumably is going to determine their prognosis. And so the way I've rationalised this is that if you are going to be cured by lymph node surgery, then either you are cured by the sentinel node biopsy, it's removing all your disease, or you have the sort of tumour that is not biologically primed to set up anywhere other than the lymph nodes, in which case it doesn't matter what time you take the lymph nodes down. And so having thought for a very long time that sentinel node biopsy is not treatment, but a staging tool, in fact, in the washout, it may be that there's a significant group of patients where it is, in fact, the definitive treatment, but it's a select group of patients. So now we observe these patients, and now they no longer need, where the trials were available, they no longer need a completion node dissection to get onto an adjuvant trial. So we do say that there is we tell them about the risk of systemic recurrence, but we tell them that their chances of being cured at the time that recurrence is found is not improved by having their lymph node surgery earlier to the best of our knowledge. Depending on what you think the risks of loss of regional control are, you can make an argument for doing it to get to say them that first recurrence in the lymph node, but in fact, people who are most likely to get a regional recurrence are the people who've got the bad risk factors that are more likely to give them systemic disease in any event. So in fact, you'd probably be, if anything, the people who would benefit are the people with the less severe disease. But we don't offer them routinely completion node dissection anymore.
So for this group of patients, if they're not in a trial, how would you observe them? Do you use clinical? Do you use imaging? Do you use any other tools?
Well, they've got lymphatic mapping. We know when we've got black and white picture with the things, we know where the pattern of second tier drainage is. We do follow them with ultrasound examination. On the MSLT2 protocol, those that were observed had ultrasound follow-up as well. So we follow them, basically at every visit with high resolution ultrasound.
So that's every 3 months, every
3 or 4 months. Yeah, but in my hands most of the time, 3 or 4 months. And so now with this post-MSLT2 circumstance, I'm looking at updating my ultrasound, so you don't have to send them out to another outside service any longer. I mean, I had tended to the melanomas to let Roger's group do it because they were the ones that used to targeting the sentinel nodes, but now they're going to get a lot of additional patients that are just coming in for routine. So this lady initially was put up for adjuvant therapy, or at least considered for adjuvant therapy, but plan otherwise had been to observe her if she wasn't a candidate.
I could just say from studying for the fellowship exam, the MSLT2 trial caused a lot of confusion within the study group because, again, it didn't really make sense based on the previous studies. But Dr. Shan, would you say that most melanoma groups in Australia and the world have now adopted the MSLT2 study?
MSLT2, oh, absolutely. Yeah. Without a doubt, and then it happened overnight. The publication came out. The day after the publication came out, I had a patient with a sentinel node in the axilla, positive sentinel node in the groin, a positive sentinel node in the neck, and at the beginning of that week, I would have been planning 3 nodal dissections, and at the end of the week, I wrote 3 referrals to the medical oncologist to consider adjuvant therapy. That was a very dramatic change, yeah.
This is just a summary of what we've discussed about with regards to sentinel indications for sentinel lymph node biopsy and the indications for completion lymph node dissection. So just very briefly, indications for sentinel lymph node biopsy in the clinically negative nodes are melanoma 0.8 millimeters thick or greater, or melanoma less than 0.8 millimeters with ulceration. Also, in patients with positive sentinel lymph node biopsy, careful observation with ultrasound surveillance are recommended, and that's grade 2B evidence. Having said that, if there's recurrence, that would mean that they should have a completion lymph node clearance. And then I've also written here that in patients with microscopic involvement of a single node, you can consider adjuvant immuno or targeted therapy with grade 2B evidence. And again, as Dr. Hong had mentioned, if macroscopic involvement of lymph node or involvement of more than one node, recommend adjuvant immunotherapy, or targeted therapy, or radiotherapy. And then lastly, it's important to say that in patients with clinically apparent regional lymph nodes on examination and also confirmed by FNA, that's when patients would go directly for a completion lymph node dissection.
Can I
yeah, well, it's sort of overlapping the microscopically positive and the macroscopically positive,
yeah.
but they're from the guidelines. Yeah.
Yeah. So just one thing. If you have like a clinically apparent regional lymph nodes, and if it's just lymph nodes with no in-transit, I would definitely consider for neoadjuvant treatment. Yeah, like trial if available. Yeah.
Oh, we might come to that.
Yeah. Oh, sorry.
So this lady was being worked up to consider adjuvant therapy. She came in for a first post-operative review, and she had developed a palpable lymph node. And so sent her off for a PET scan, and the PET showed palpable lymph node. It also highlighted a radiologically evident lymph node in the contralateral neck, which was also, that was radiologically significant. But and in retrospect, I was able to find clinically we needled that, so she now has bilateral macroscopic lymph node involvement relatively quickly after her positive sentinel node. So she wouldn't have even made it to the 3-month first ultrasound.
So Ines, would you offer this patient something now?
Okay, so if the patient is eligible for the clinical trial, considering that those would be regional, what I mean by eligible is, for example, immunotherapy trial, just keep in mind that a patient that needs to be fit, of course, cannot have any autoimmune disease, a few rules, but if the patient is fit and if she's eligible and if she's keen, I would definitely consider at least a discussion with the patient for a neoadjuvant trial.
There's nothing off trial at the moment.
In the neoadjuvant setting, no. But just to give you a little bit of information, so we have this consortium where we are trying to do around the world different clinical trials with the same design, which means like treatment within 3 weeks before the surgery. So the goal is don't delay the surgery too much. So we don't want to lose those patients that like were resectable and then they are not resectable anymore. We don't want that. That's why it's like 6 weeks, different designs. So we had one that just closed and another one that we have.
So the context of this lady's BRAF positive, what's available?
Okay, so for BRAF positive, we have the NeoTrail, which is a trial where we combine immunotherapy and target therapy. So the same drug that I mentioned before, so the brafenib, trametinib, and then is a similar PD-1 based from Novartis, which is the detail. But and then we have 3 arms, one where is immunotherapy alone, so PD-1 alone, another one, and what I mean by it's neoadjuvant and adjuvant, so it has 2 components: 3 weeks before surgery and then to complete a year. We have 1 arm PD-1 alone, another arm where we have 1 week of target therapy followed by PD-1 alone, and then the other arm is 3 weeks of combined, the 3 drugs, and then PD-1 alone. What we know so far is target therapy from previous trials, target therapy in neoadjuvant setting, and if we correlate complete pathological response and overall survival or like recurrence, yes, there's some benefit, but the curves, they go together, so they drop. If you do immunotherapy and if you have a complete pathological response, the curve is amazing. So we need probably immunotherapy, and we think, like early days, that the immunotherapy prior to surgery, so in neoadjuvant, it's better in terms of outcome, but we don't have a direct comparison. Okay.
So the previous targeted therapy trial, so there's a MEK inhibitor, a BRAF inhibitor in combination. What were the findings of that so far? So that's neoadjuvant combi.
Correct.
Yeah.
That's neoadjuvant combi. So that design was slightly different. Was 3 months before, so it was before that consortium. So 3 months of the brafenib and trametinib, and then surgery, and then 9 months, right, to complete a year. And what we saw is that yes, we are able to have complete pathological responses, but then when we try to correlate that finding with recurrence afterwards, again, so we see that both curves, they drop. There's a slight benefit when you have pathological response compared to without, but both lines, they drop, right? So when we do the same with immunotherapy, that's when the benefit. So when we did the other trial called Opacineo, 3 weeks, only with immunotherapy, the combination of ipilimumab, which is a CTLA-4 blockade antibody, and PD-1, 3 different arms, just different combinations, but definitely different doses, but the same combination, 6 weeks surgery, and nothing else. That's why we are getting this flat line.
We're getting about 70%.
Of complete
or near pathological response.
Yes, 40, I think, complete pathological response, and 70 is.
And the amazing curve you're talking about was that in the immunotherapy, people who have a complete pathological response, there have been no progression.
Yes. So far, yes.
So,
yeah, but what we were saying is that I think that line is not only the complete pathological, but also the near complete.
So, people that might have 10% residual tumour, that's considered almost the same, having complete pathological response. It's still in that same curve.
So this lady, if she's BRAF positive now, she would be offered a combination targeted therapy, immunotherapy trial.
That's the only that we have available right now.
Right, if she's BRAF negative?
Then only immunotherapy, but we don't have anything open right now. We'll have.
Nothing open at the moment for immunotherapy.
And again, we're not allowed to prescribe those drugs. Well, we are allowed to prescribe, but it needs to be paid by the patient.
So, in summary, high-risk tumour, macroscopic disease, they're all considered for neoadjuvant therapy, as this lady was. But unfortunately, one of the eligibility criteria is that the smallest dimension of the target node had to be 15 millimetres.
Exactly.
And hers was about 11. So she was not eligible for neoadjuvant therapy. So she fell back on standard management.
And standard management, so it's confirming the diagnosis preoperatively with FNA cytology and staging, with PET-CT, MRI brain, and CT brain, or CT brain, chest, abdomen, pelvis. And obviously a completion lymphadenectomy recommended for patients with palpable or imaging detected lymph field recurrence. Should mention, obviously, one of the drawbacks of doing a completion lymph node disease is obviously the risk of lymphedema compared to just a plain old simple lymph node block, which is roughly about, is it 24% the risk of lymphedema?
Not that high. Certainly in the axilla and the limb, the rate of measurable lymphedema is about 16%, that's my understanding. It's actually lower in melanoma for the axilla than it is in breast, and I think that's probably because taking out some breast tissue probably chews up a few more channels which contribute, but we actually don't, and that's 60% measurable. It's only a small proportion of those that actually have major symptomatic problems. And probably only 1 or 2% will have the big heavy swollen limb, but they can't do anything. It's actually very rare. And considering we do a more extensive lymphadenectomy in melanoma than they do in breast cancer, for axillas, for example. In the neck, lymphedema, spoken about, but it hasn't really been a big problem in my experience, particularly when we're not giving radiotherapy routinely and we're doing selective operations for the most part. I could name one person who's had a terribly bad infection in their ear, which might have been worse because they had no lymph nodes draining that area, but then they might have just had a bad infection. In the skin patient, in the melanoma patient in particular, the lymphedema has not been a big.
And this is kind of a slide just summarising surgical treatment and the adjuvant treatment.
So, Kerwin, just to go back to this patient, she initially had got bilateral sensory lymph node. She fell on the contralateral side.
So she had bilateral occipital, bilateral. So one was sort of level 2. So one was postauricular, one was occipital on one side, postauricular and level 5 on the contralateral side, the apex of level 5.
So she fell on one side. Would you then offer, when she recurred?
Or if she failed on one side.
She recurred macroscopically on the left side, nothing on the right side macroscopically.
No, after her imaging, there was something on the contralateral.
On the side, okay.
But if there had been nothing to suggest failure on the contralateral side, I would have done a unilateral operation. If she failed on one side, I would.
How do you plan your unilateral operation? As in, do you look at your initial scintigraphy to see where?
I always do a completion lymphadenectomy based on the pattern of drainage, second-tier drainage demonstrated on the scintigraphy. And so from a posterior scalp primary, draining behind the ear with no drainage through the parotid bed, no sentinel nodes in the parotid, my plan for her was occipital and levels 2. Essentially a posterolateral dissection, including the postauricular and the occipital. If one of the sentinel nodes had been in the parotid tail, for example, then a parotid would have been added, but there was nothing on her mapping to suggest that she had anterior drainage, and her nodes were not in the parotid tail.
So, Angela, at this point, do you have a role for this patient after the next?
So I would like to see the pathology. So it depends on the size, the number of involvement, and any extranodal spread.
What are your criteria?
So in the head and neck region, any process disease, or 2 or more in the rest of the neck, more than 3 centimeters in size, or any extranodal spread. So there was a 12 study, Australian study, randomizing patients to have, well, they all have surgery, they're randomized to have surgery, radiotherapy, or observation. And that showed a significant reduction in the nodal field relapse. Radiotherapy is a local treatment, so will only impact on the regional control. There's no overall survival benefit for adding in radiotherapy. And in that study, the strongest predictor for nodal recurrence, in fact, is the extranodal spread. Yes, you're looking at hazard rate of about 2.6 with an extranodal spread.
What sort of dose would you be talking about in the adjuvant
So
study?
the study was 48 square infection, so over 4 weeks. That's the standard dose, and that's what I would use. It's well tolerated in the head and neck region. Unless it's a big spill in a younger patient, they're really worried about potential long-term toxicity, then I'll put it down to 2 grams a day to 54 grams.
And where would you cover? Do you look at the scintigraphy to guide you, or do you have a standard protocol?
Yes, the nodal field, the operation
The surgical field. Yeah,
surgical field, yes.
So at this point, so you had surgery. There was no trial beforehand for neoadjuvant. You had surgery. Would you offer something depending on what Angela say, or do you offer something independent of what Angela?
Well, I mean, this is a question we haven't yet answered in the squamous cell carcinoma patients. The study that sort of John spearheaded, looking at the pattern of nodal failure, where we found that if this is, for example, people who've got disease in the parotid. This disease in the parotid clinically negative elsewhere. You know, if there was no disease in level 2, it was never anywhere else, and if there was disease in level 2, there was a risk it was elsewhere. And so we changed the pattern of the extent of the radiotherapy based on the pathological findings in a small area that we take out rather than a big area. We don't know that sort of behaviour is that we can rely on the radiotherapy in melanoma. It may be that we can, but we haven't really looked at the numbers yet. So in other words, if it's clinically negative down here and we remove the area where there's macroscopic disease, can you salvage the rest with radiotherapy? We don't know. But I tend not to rely on it, because I'd rather give them no radiotherapy and if they've got a clear dissection. But I guess that's something we can still look at. And I thought Sydney had started to look at that Johnson ago, but I don't know where we're at. So whether she's going to give radiotherapy or not, I will still do a complete lymphadenectomy. It's something that, the Sydney melanoma at MIA for a long while have been very aggressive surgical people, and the outcomes from that unit have been very good, so we tend not to back off. I remember even Don Morton saying when his first look at the MSLT1 data, he said, well, what have you learned from this? And he said, I've learned if I need an operation, I'm coming to Sydney. We had over 50% of patients in that. But we can still do selective operations if the drainage hasn't gone through that field. And I've not, I must say never, but very rarely had in melanoma patients failure out of the field in the absence of disease at other sites.
So that's a good point, because the data that I mentioned about the adjuvant trial, it's like the last one that we don't have that much data, but there is an interesting trial that we just closed, adjuvant. That was the only one that we could offer the patient, not at this time that she came to us, but it was a comparison between nivolumab versus ipilimumab plus nivolumab. That's a new one. And in that trial, they did not allow radiotherapy. There was so we have several discussions in our MDT, because some patients, they definitely would think that they would benefit from radiotherapy independent of systemic treatment. So in general, so when I see a patient, I always send to Angela to discuss when there are risks that she mentioned, and that's independent of systemic treatment. we don't know the answer to your specific question, but that's how we normally.
So if someone's going for a clinical trial, will be closely monitored by clinical follow-up, again, more than comfortable to watch results on therapy. Outside, say, if one day the PPS listing is available for adjuvant therapy, I think the study you mentioned also show a benefit in terms of the reduction in nodal relapse as well with adjuvant systemic therapy. So I think it will be very reasonable to observe the area.
So summarizing, definitely the cases that you would treat with radiotherapy, they are discussed in our multidisciplinary team meeting too, because if the patient goes for adjuvant treatment, probably, I agree with Anne's point to start radiotherapy up front, we might just watch closely. But if a patient does not is not fit enough to do adjuvant treatment or cannot be or not eligible for the trial, definitely would go for radiotherapy.
In interest of time, then, we might move on to the last case. Actually, Colin, do you want to make a comment? You sort of draw.
Yeah, it is my, that bottom line on the right here was just thinking I did one line, then I changed my mind. But my usual policy is to remove the scar through which I pull the positive sentinel node out. The trouble was here I had two. There's a question of, well, which of these am I going to deal with? Should I just take that out and do a separate decision? Should I just leave it intact and lift the flap up and come back towards it? And I chose to do that. But what happened in this study is as I lifted this flap up, I encountered macroscopic mutation deep to this scar, which I initially thought might just be the sentinel node tattoo ink. When we sent it for frozen section, they said, no, it's tumoral melanosis, we can't tell whether it's viable or not. And when we did the dissection, and her positive node on this side was about here. The one that failed afterwards. So then we had this situation of extranodal tumour deep to that scar, which I had removed macroscopically, but in a not very oncological fashion. Multiple lymph nodes on that side, node on the other side. I think it was just a single one, wasn't it? And that very discussion that you've just spoken about, then if she's a candidate for adjuvant therapy, she'd go straight to that. And it turns out she wasn't able to afford it. And so now we've got this very high-risk disease in the left neck. And so because she's not having adjuvant, she is actually going to have now radiotherapy to cover that left side only, I presume. You're not going to do the right, because that's where the multiple nodes and extranodal spread are both present,
So her left levels 2 to 5 were clear, and her right levels 2 to 5, there was 3 out of 5 level 5 lymph nodes involved. On the right side, there's 3 out of 5 level 5 lymph nodes involved.
Oh, level 5, but there was a positive node on the other side, but it was a single.
And the central lymph node scar was involved. On the right side.
So we might move to the very last case. Have a slightly different aspect of melanoma. I think we have spoken a little bit of what we want to cover in the second case. We might run through them to the...
It's just exhibiting bloodless surgery. Trying to get to all these specimens. We've already talked about systemic therapy, so we'll just run through this with just some diagrams on the line.
This one is the last one. Sorry, Andrew, I'm not putting a bit of effort on this one.
That's all right. So the issue in that second case was just very bad local disease in elderly patients. Yes, put this one on as an afterthought for you, Angela. So this is a chap who recently came over from EMEA. He'd had a lesion taken off the side of his nose late last year. He wasn't told the diagnosis. Turned out to be a melanoma, and it was only when he recurred that he got sent in to have this assessed. He had a wide excision. I don't know if you can see there's a flap sort of run up this way. I think it's outrun, which all healed up beautifully, but the pathology showed desmoplastic melanoma, extensively involving the deep margin with evidence of extensive perineal spread.
Going back one step, when he first noticed something wasn't right, was actually just a lump on the skin. There was no ulceration on the skin. He said there was a bit of tingling in that area, but a lump on the skin. So
So then we were pressed with the situation where the biopsy allegedly has been down to the nasal skeleton, or the original incision has been down to the nasal skeleton. It's got a positive deep margin, but a perfectly well-healed flap, asymptomatic, and no macroscopic tumour, but extensive perineal invasion.
So, Robert, in the very early slide, it sort of shows that the pathogenesis was desmoplastic, but being very different to a normal. Can you give us a sort of broader review, or sort of a damage guide on why it is? And
Well, generally they arise in some damaged skin, about 50% of the time from lentigo maligna, so it tends to be coming from that chronic sun-exposed pathway. And it appears morphologically distinct from a normal melanoma. So desmoplasia histologically looks like individual cells which are separating from each other and going through thick hyalinized collagen. That's how we define it. And generally it is thought to have a high risk of local recurrence, usually due to the fact it has a high propensity to involve the local nerve. However, it seems to have a better prognosis in the fact of spread to local lymph nodes. And there's some tumours which have small parts of the invasive melanoma as desmoplastic, and they're the mixed type of melanoma, and then there's the pure desmoplastic melanomas. And this was almost purely desmoplastic melanoma, so more than 95% of it was desmoplastic. And they're the ones that seem to have a better prognosis in spread to distant sites like lymph nodes. So it seems to be coming down that chronic sun-exposed pathway, not the BRAF mutant type, more than 50% of the time involved with coming from a lentigo maligna precursor. Sometimes you don't even find a precursor lesion, but there might be an increase in melanocytes overlying it. But a very difficult lesion pathologically, probably the biggest risk of pathologists missing a diagnosis and litigation to pathologists is just taking it and thinking it's a scar. And actually just can look like a scar. This was a really fulminant version of it. So it is a very troublesome lesion for us to diagnose.
Was any staining happening?
Yeah, so these are generally melanoma and HMB45, two of our melanoma markers. They're generally negative for those two, and only usually the pure types are positive just for our S100 marker, our SOX10 marker. So for some reason it's losing some of the melanocytic differentiation of the expression, and it's just that I suppose the more sensitive markers are still positive. So that's what we use, but then that introduces a whole other sort of differential diagnosis of is it a neural tumour or is it a melanoma? That's what neural tumours stand for.
So, Kerwin, you did you sort of offer something unusual for this patient?
I don't know about unusual. The question was, do we operate or not? He's got an indication for radiotherapy anyway with the extensive perineal spread, and the surgical option here was to remove part of his nose. It was presented at the MPT. There was some discussion about whether he'd be a candidate for some immunotherapy. There was a precedent recently where John stressed, and I would have liked to present this case, I didn't have all the clinical details, had a big desmoplastic melanoma on the nose, lady didn't want a nose off, so they decided to give her some pembrolizumab. She had a partial response, is that correct?
Yes.
But then appeared to progress, and so then radiotherapy was added.
Correct, 6 degrees.
Yes, but she stayed on the pembrolizumab and got a complete response. So the thought was here, well, radiotherapy seemed to be the thing that did the trick, and if you can get some pembro as well, that might be something to try. But the problem with giving pembro is that we haven't got anything to gauge response with. There's no mass that's left behind, and so I think the plan was to give definitive radiotherapy. But then the question is, well, what's the extent? At risk here, there was some tingling in his initial presentation. Is the infraorbital nerve involved? And if that's involved, does he need to have radiotherapy back to his skull base? And so the plan was for me to biopsy the nerve. So I took him back to theatres, and as you know, sometimes you have a positive margin and then you do a wide excision, there's nothing left. I said, well, we'll just see if there's any residual disease behind. So I actually took an extra margin on the primary and just advanced that flap a little bit further forward, biopsied the nerve at the foramen and a little segment beyond it, and the result came back saying that the nerve was clear. So we didn't have to worry about that V2 distribution, but there was still desmoplastic melanoma at the deep margin of the resection with extensive perineal spread going to the deep margin. So in fact, there's still, despite the second, or probably now the third excision, there's still evidence of tumour there. And so I represented and asked him, well, should we still be persisting with plan A, and I think the plan is to persist with plan A. And give him some radiotherapy and deal with, accepting that with a pure desmoplastic melanoma, although the risk of nodal metastases is not zero, it's certainly a lower risk than in mixed forms. And so that if he's going to get a problem, it is more likely to be a local one. And then we've got options to deal with that down the track.
Just so that we don't send the wrong message. So in a typical desmoplastic melanoma, you still treat with surgery?
The aim would be to resect to clear margins.
Surgery.
Yeah.
With sentinel lymph node or without sentinel lymph node?
Look, I would do a sentinel lymph node biopsy because, as the head and neck surgeon, I have a long list of patients with pure desmoplastic melanomas that have metastasized. So what proportion that is of the whole desmoplastic melanoma population, I'm not really sure, but it does happen. And so forth. And because these are usually thick melanomas, so I'm guided more by the thickness of the primary than the fact that it's desmoplastic. But I do tell the patients when I do sentinel nodes that I expect the risk will be lower, but it's not zero.
And would you routinely then offer a desmoplastic melanoma with adjuvant radiotherapy?
So depending on the margin, so you can see the recommendations there. So that's based on the large study at MIA, 671 patients with neurotropic melanoma. About 88 had adjuvant radiotherapy, so this is retrospective analysis, and shown that those with a pathological margin less than 8 millimeters, there's a benefit in adding in radiotherapy. So,
what about PNI and things like that? Would that be an indicator for you to offer adjuvant?
so depending on the margin, yes.
Just margins, not PNI. Yeah.
So if they have good margin, more than 8 millimeter, I will know the skin is getting. Typically, it's in the head and neck region, so there's toxicity getting in radiotherapy.
The adjuvant radiotherapy trial for desmoplastic still running?
There is a randomized study run out of Queensland for neurotropic melanoma of the head and neck region after surgery with clear margin randomized into radiotherapy or observation. The trial is recruiting very slowly, looking for 120 patients. I think they're up to about 40, 45 patients.
After a good number of years.
The number of years,
You've got
so
patients,
might not fully recruit.
you've got patients with desmoplastic melanoma. Not sure whether to give them radiotherapy or not, to put them on a trial.
And what about immunotherapy or systemic therapy for desmoplastic melanoma?
Well, if the patient high risk of recurrence, stage 3 definitely, right? I would follow the same rules as we mentioned before. Just one more information about this. This is a specific type of melanoma. As Rob mentioned, it's like it's due to chronic stem damage. We have more mutations here. They respond really well to PD-1 alone in general. So, for example, I know it's a little bit outside the scope, but for example, we had recently a patient with different metastases, including brain metastases, and we were discussing Ipi-Nivo. Yes, we get Ipi-Nivo just one cycle, but because in general responds really well to PD-1 alone, we keep it simple in general with these patients here. That particular patient we discussed about the nose was a rare case. We are going to publish, but she definitely responded really well in the beginning, and then like 3 sites of recurrence, local recurrence, and then by adding radiotherapy, amazingly, complete response, and she's been really, really well.
So there was a Nature publication looking at desmoplastic melanoma with response rates to anti-PD-1 alone, 80%.
Yes.
Even histologically in desmoplastic melanoma, we see tumor infiltrating lymphocytes in the normal lesions. That's one of the clues we look for to make the diagnosis of seeing lymphocytes. It's into why the immunotherapy.
Correct. Yeah.
So do you want to run us through some of the histological finding, and then we might then wrap up for this session?
Sure. Basically, recapping, I think everything Rob has said. This is from the re-excision. You can see this deep margin is involved. Even at low power, you can see there's quite a lot of inflammatory activity. These are lymphoid follicles. And then at high power, we've got dense collagen bundles set with single cells. So in contrast to the melanoma I showed earlier, this is quite a different morphology. It's single cells with lots of fibrosis around There's no pigment in these. I think again, the negativity for melanate and HMB45 corresponds to the fact these do not have pigment. That's really it. And you'll see there's a smattering of lymphocytes across this, consistent with probably the increased neoepitope present in this lesion.
So sort of to wrap up, so follow-up for both desmoplastic and older childhood melanoma, is this purely the same 3 months for everyone?
We had this discussion recently at our MDT. As I mentioned before, there are no guidelines, so we are writing up, like trying to put together what has been discussed previously, and with our experience in our center, putting together something that would fit for everyone. But yes, we are going to include desmoplastic in the same group, and it's going to be something between like 3 to 6 months and first 2 years with a PET scan and MRI of the brain. That's in general.
At the 2 years mark or at the regular?
Now, every 3 to 6 months we are deciding that timeline for the first 2 years, and then of course like more like yearly after. But we are still deciding on that.
No, so that discussion's about investigations, what sort of staging investigations do for the high risk. In terms of just the general follow-up, Jeff Gershenwald presented some data some years ago where he looks at the risk of recurrence over time, and for melanomas that are intermediate or thick, the risk of recurrence sort of reaches a peak at about 12-18 months and then falls and continues to fall slowly over time but never flattens out and never reaches zero. So our follow-up, we see them more frequently during that hump, which is the first 2 years, and whether it's 3 or 4 months, just depends on how. I tend to see them every 3 months for the first 2 years, see them every 6 months over the next bit of a slope, and then it slows down. For the thin melanomas, the risk of recurrence over time is in fact a flat line. So there's no point in time for an in situ or a thin melanoma where you're at any greater or lesser risk of recurrence. So you can basically pick an interval out of the air as to how often you see them, and I tend to see the thin melanomas in situ every 6 months.
So if the curve never flattens out, do you ever discharge the patient?
Never. Well, if I may discharge them from my care, but I don't discharge them from follow-up. So if they're discharged from my care, they are discharged to someone else, so a dermatologist or a GP who's particularly keen or something of that sort.
And in terms of imaging during a follow-up, so you mentioned you monitor the lymph node.
Up until recently, I mean, what I had tended to do for the stage, so stage 1 and 2, there's no indication to do staging scans of any sort. For the stage 3s, I tended to, once I'd made a diagnosis of stage 3, I would stage them. Originally, it was done to find a reason not to do a big regional node operation. Now I tend to do it to see whether they're eligible for a trial, but they were staging with PET and MRI at diagnosis of stage 3. And up until recently, I used to do an early scan at 6 months, and then if that was clear, I do it once a year.
So the early scan being PET and MRI?
PET and MRI, yep. Now with news, and that sort of follow-up was in the past at a time where we really weren't sure that we had anything that we could give people if we found something early anyway. But now there is evidence of drugs that work, and there is some evidence to suggest that the earlier you get it, the better it is. So whether that's just a lead time bias, we don't know yet. But there is now an incentive to find it a bit earlier, and there is some data which I don't have in my head, but I remember Georgina talking about it, to talk about when the first recurrences are turning up, and there is some suggestion that there's a significant proportion of people who do turn up within 3 months.
Yes.
And so now there's a question of, should we be doing it every 3 months, or do we do a 3-month scan and 6 months and then whatever? But that's the discussion we're having. How often we should be doing it, and then how long we should be doing it for.
Exactly. So all the trials, so when patients on trial, it's easier because they have every 3 month scans. So we're trying to put together all this evidence and data and see exactly what's the best schedule for the scans. But definitely PET scan and MRI. If they are on treatment, we get CT scans instead of PET scan, and we do yearly a PET scan. if they are on adjuvant treatment.
So in one sense, it's become easier for me now because they get sent to the medical oncologist who then start to follow them up and do scans according to their protocol.
So,
well, the other side of the coin is if someone has a symptom which suggests systemic disease, and local recurrence is a symptom in my mind, so if someone gets a local recurrence, I'll restage them. Then I've got a very low threshold for all those. When they were asymptomatic in the past, before these things, I had a very high threshold for scanning. But anyone who's got, unexplained weight loss or having some dizzy spells, what I tell the patient is something that is new for you, something that is progressing over time in terms of its frequency, duration, or severity, something that doesn't go away in the time you'd expect it to. And if so if someone's got a cough or a chest pain or something, if they've got a flu, you'd expect them to feel lousy for a week or two, cough for a couple of weeks after that, but then it should go. If they come back to me and say, look, I've had this irritant cough for the last 6 or 8 weeks, I'll scan their chest. Because I want to rule out melanoma as a cause. There might be 100 other things that could cause it, but I'll do those.
and there's a CT scan of the chest with a pen.
Well, that's investigating the symptom. Yeah. Yeah. And so I'll investigate that symptom. Appropriate.
I might open the question to the floor if there's anything else everyone would ask. I've started losing quite a lot of people along the way. It's all for today, sorry.
Just wanted to follow up. Imaging, MRI scan is targeted for the primary
Brain. No, MRI of the brain.
brain.
Brain, yeah.
So
Melanoma has a high propensity of spreading to the brain, and PET scan is not good for detecting small brain metastases.
imaging for the primary site, which is critical.
No, so if you've got primary only disease, that's stage 1 or 2. We don't scan. But there's some people for the T4s. A lot of people get referred to me with having had staging for a T4 prime, but I'm usually guided by the sentinel node status because anyone with a T4 is going to get a sentinel node biopsy. And if they're sentinel node negative and asymptomatic, I wouldn't necessarily scan them. Although we haven't reached this topic, but there's a stage 2 trial coming up, stage 2 adjuvant trial coming up.
What I mean is how do you pick up a local recurrence if it's not clinically?
A local recurrence.
Yeah, or is it not?
Clinical examination.
There's not imaging for.
No, so they're able to develop a lump or they've got new pigmentation.
Another question. You mentioned the targeted therapies and the immunotherapy not required. What are the costs? There's an estimate. So you mentioned it's a long treatment for a year.
So it's a long treatment. So for immunotherapy, which is the pembrolizumab every 3 weeks infusion for a year, it's around 100,000 for the year. But then the company sponsors around a third. So for the tablet, it's more expensive. It's around 160,000.
Do you actually get a lot of people who go on those?
So we have only one patient having the reference to the tablets, which is most expensive, because this patient was on the immunotherapy adjuvant trial, and he recurred at the first scan, so 3 months, on the combination ipilimumab and nivolumab. So we don't know if that combination is better than nivolumab alone, but we know that nivolumab alone by itself is already really good. So assuming that it has good health, so this patient is really high risk here. So he was really keen to do everything that he could. So basically he recurred, was also recurrent resection, and then he came to see us and say, I want to do anything I can do right now to reduce my chance of recurrence.
Okay.
And then on pembrolizumab adjuvant, we have a couple, not many, but a couple.
But we have many candidates.
We always discuss it. It's an unfair discussion, I think. I think it's fair to have the discussion, but it's unfair to get the decision. It's like financial possibilities, unfortunately. But I think we'll get there. But we always discuss everything. So, for example, we explain that those drugs are really effective in the stage 4. So we explain the risk of recurrence is local, but also distant. We discuss everything, and patients are aware. And I think, I think they leave our room with a clear idea and decision.
So that lady who presented an example, had the discussion at the time she was sentinel node positive, she had the discussion at the time she had macroscopic disease, and she had the discussion after we'd resected her macroscopic disease, and all of that. And she was, in a sense, details or most of the way along the line, but she's still going to hold off and wait for the stage 4 disease to have it.
Yeah, exactly.
Because otherwise, it's noisy if we're treating something that's in there.
Yeah. Can I just make one thing that Colin mentioned, but I think just to highlight it. So for the neoadjuvant, we use and for all trials we use RECIST criteria. So that's why for the lymph nodes, it's like the short axis needs to be greater than 15 or greater than 15. So if you want to refer patients for a neoadjuvant, yes, that's true. So that's a really important criteria. Otherwise, we don't have anything to kind of measure. And the same, so for the last case, where we cannot give systemic treatments because we don't have anything to measure. So how can we, so in general, we have to have something to measure in the scan so we can see, say, the response or not, just to clarify.
Just to finish up, the Melanoma Institute has developed, where there is an education committee, and they've put together this education portal. So it's worth having a look at. You do need to sign up, but it doesn't cost anything. But one of the advantages of signing up is that will give you access to an iBook, which is essentially a textbook that's been written by the members of our department, which is, it's a pretty extensive book. You can carry on a phone or an iPad or something like that. There's lots of pictures and interactive diagrams and videos and all sorts of things about melanoma management, and that's a very valuable resource. So if you do nothing else, sign up, download the iBook, and whether you come back again or not is irrelevant.
So I might close this session. So I'd like to thank Daniel and Andrew for putting together this presentation, and thanks the expert panel for making their way here. Thank you.
I think that's stock picture, isn't it? Stock picture somewhere. Someone from marketing downloaded that off the internet.